Well, time is precious, and I want to wish all of you good morning, good afternoon, and good evening, depending on your geographic location. My name is Dr. Charles Drum. I'm an aging white male with graying hair, and so I've been told by a person or two, blue eyes to die for. My pronouns are he, him, his. I experience a non-visible disability, and I've been a disability researcher advocate for a number of decades. I'm also the director of the Disability Community Engagement Partner Project, or DCEP, as we call it. It's based in the American Association on Health and Disability. DCEP is funded by the National Institutes of Health All of Us Research Program, our sponsor for today's webinar. Welcome, all of you, and I'm so grateful for you to attend the No Research About Us Without Us, the Promise of Disability and Health Research webinar. This is the first in a 5-part series focusing on disability and health. It's my distinct honor to be serving as the moderator for this panel. I want to cover some housekeeping items first and foremost. We have both CART and an ASL interpreter with us today. So please, panel members, don't get too excited. Keep your verbalizing to an even cadence. I've been yelled at a time or two by an ASL interpreter. It's not very much fun. For audience members, please use the chat feature to let us know if you're having any accessibility issues. For questions for the panelists, I would ask the audience to use the Q&A feature on the Zoom platform with your questions, and it would be helpful if you identified who you are directing the question to. Panelists will also be posing some questions or weighing in on the topic of being led by each of the different panelists. So we're not fighting, folks. We're just having a nice, pleasant conversation. If we don't get a chance to answer all of the questions in the Q&A, we'll be recording them and developing responses and circulating that to the audience later. Really importantly, there is an evaluation survey that will be shared at the end of the webinar. Please complete it. It will help us so much. We want to get this webinar series right. For those of you who like to Google while you listen, more information about the All of Us research program will be available in the chat periodically, and it should be screen readable as well. So I get the distinct pleasure to cover a couple of different things today. At first, I'm going to talk about the All of Us research program, but very briefly to kind of set the context for our subsequent conversation. I'm going to let you know what it is that the Disability Community Engagement Partner Project does at AHD. I'm going to talk a little bit about an inclusion statement that the project developed. Then I'm going to ask each panelist to introduce themselves, and that will then be the focus of the subsequent conversations. So what is the All of Us research program? It's a monumental undertaking to enroll 1 million people or more into the All of Us research database. Data can come from a number of different sources. People have a choice at the level that they want to participate. It's all about choice. People, once they're registered and enrolled, can choose to submit their electronic health records to the program. They can provide a biomedical sample so that genetic analysis can be done. They get to answer surveys, which is part of my favorite part of it. One of them is the social determinants of health. There's an opportunity to be part of a long-term research programs going on, research projects. There's over 6,000 researchers that have signed up for access to this data. The data is all de-identified. It's in incredibly secure settings. One of the benefits of the All of Us research program is the goals that they have. The primary goals are to do research that improve health and that advances precision medicine. Precision medicine is this notion that people have individualized healthcare rather than the one-size-fits-all approach that we see too often, particularly with our community. One of the other things that the program is doing is emphasizing the inclusion of people that are often left out of health research. And by that, I mean people with disabilities, gender, mainly women, racial and ethnic minorities, rural populations, LGBTQ community, all the folks that are often left out of health research are really being focused on to have people participate in this particular program. So what does the DSEP project do at AHD? Well, our side of things is really around recruitment of the disability community into the program. We do outreach and engagement, educational programs like this one, so that people get a little bit of interest in this particular research program. We're doing education of researchers, trying to tell them about the value of using this particular data set to advance the health of people with disabilities and advance precision medicine. That's our primary role. We have a secondary role. AHD is a mission-driven private nonprofit that focuses on health equity. Part of our responsibility is that we need to hold the program accountable. Where they're doing a good job, we tell them. If they're not doing a good job, we tell them that as well. And we provide foundational information to them. Things like how you include people with disabilities in research. That's going to be addressed today. What are the technical aspects of involving people with disabilities in research? Dr. Harniss will be addressing that. How does the program look like from a participant perspective? Anthony Oberg will be addressing that today. Part of what our program did is develop an inclusion statement that was formally approved by this NIH-funded project. It focuses on the importance of including people with disabilities in health research. It calls for the program to adopt accessibility best practices, not just 508 compliance, but adopting the best practices available. It calls for research focusing on disability health equity. It also calls for the inclusion of all people with disabilities, whether they can provide consent or not. Now, we're not doing this alone. We have a partnership of 24 national and local disability organizations that are helping us get out the word about the All of Us research program. We value those partnerships very much. We also want to turn today to some of these foundational issues of inclusion and access and perspective from a lived experience about disability and health research more broadly. So at this point, I'd like to ask each panel member to introduce themselves. We'll start with Anthony Oberg, and then turn to Mark Harniss, and then Megan Tracy, and then there'll be questions that I'll be asking each of them to share their responses with this audience. Anthony.
Thank you, Charles. It's a pleasure to be here and appreciate that introduction. I am Anthony Oberg. I am a 33-year-old white male. I have brown hair, wearing glasses, and a beard. I am currently working at the National Network of Public Health Institutes, but my general professional background, and as Charles mentioned, lived experience is around disability. Specifically, I have cerebral palsy. As Charles also mentioned, I am a participant in the All of Us program. I've taken many surveys. In a past life, I worked with this team at AHD on the DCEP project. So I'm pretty familiar with the work and the program, but was happy to come and talk to you all about my experiences, both lived and professional, with disability, 508 compliance, and share that expertise with you all as it relates to this project. Thank you.
Thank you. Mark?
Yeah, hi everyone. My name's Mark Harniss. I'm a middle-aged white man with brown hair and blue eyes. I use he, him pronouns. I'm wearing transparent reading glasses and a black collared shirt. Relevant to our discussion today, I do not identify as disabled or as having a disability. I have family, friends, and colleagues with disabilities, and I've worked in spaces related to disability for many years, but I position myself as an ally. Professionally, I'm an associate professor at the University of Washington in the Department of Rehabilitation Medicine, and I lead a number of projects, mostly funded by NIDILRR, related to disability, including a project focused on the American with Disabilities Act. It's great to be here.
Thank you, Mark. Oh, dear Meg.
Hi, I'm Meg Tracy, and thank you for that introduction, Charles. I use the she, her, hers pronoun series. I'm a middle-aged white woman wearing a black cardigan today with a pink button-down top and a pink and black necklace. My hair is long and brown, and I am white. I'm using a virtual background that is a green field with wildflowers from the eastern front of the Rockies here in Montana. I position myself as a non-disabled woman, having worked in the field for 30 years and as an advocate for social justice and disability rights. I'm a developmental psychologist, experimental psychologist by training, and have been working with the All of Us research project and AHD and the DCEP team with our Centers for Independent Living here in Montana, really wanting to look at what the program is offering in terms of its promotional materials, how it's representing the diverse disability community, and helping to host promotional events, and really helping to think about how those events can be more inclusive of people with disabilities to learn about the project and participate if they are interested. So happy to be here. Thanks for organizing this opportunity.
Thank you so much, Meg. And I'm a little more casual with Meg. What's that?
Sorry, there's a question in the chat already. Just a quick clarifying question from Tamara Huntley. The question is, what is 508 mean, or what does 508 mean? So Anthony, that's probably directed towards you. If you could take a quick, just so everybody is on the same page.
Yeah, that's perfect. Thank you. I was typing it in the chat box, but I will say it out loud. I apologize for that. 508 is shorthand form referring to accessibility practices for digital media. It is something that I have technical experience in, and it's all about making sure that materials that are public facing and beyond that are readable to all people who need them, whether they have visual disabilities or other kinds of disabilities. And Charles or anyone else can add to that definition if needed.
I think that captures it. It's Section 508 of the Vocational Rehabilitation Act that mandates the accessibility of these publicly facing materials, as well as websites. So let me turn to the first question that I have, and that's for Meg. And I'm a little casual with Meg because I've known her, I think, for about 25 years now, or something along that. Meg and I started in this field when we were 8 and 10, respectively. So, you know, it's been a long time. But here's the question that I have for you, Meg. It's a beginning question. You know, we're talking about the All of Us research program. We're talking about this inclusion statement. And I should be praised for having this focus. But what I want you to answer for me, please, how did we get to this place where it's a big deal to include people with disabilities in research? And I think our other panelists may have responses to that as well. Why was the disability community excluded from health research for so long? Do you have some thoughts on that, Meg?
Yeah, Charles, this is Meg. And I was trying to think about this, and I think I've chosen to talk about kind of, for me as a researcher in the field and a public health practitioner, just kind of the origin story that hooked me and really resonated with me as somebody who has family members, 3 who have been institutionalized because of their disability. And it's the story of Mike Marge going to the National Council on Disability. And for those who aren't familiar, we'll include an article that kind of details that. But this was in the late 80s when Mike Marge was asking for more money for public health, with very much folic acid and preventing spina bifida in mind. We have an intervention, we need more money for it. And through multiple presentations to the council, Mike finally shifted his power to the council and asked the question, what can we do for you? And I'm kind of paraphrasing, I'm taking this forward, but I mean, it involves Theodore Koop going and pounding the table, saying, I don't understand why you won't approve more money for public health. And the council said, we're not in the business of funding the prevention of people like us. We're here and we want to support people with disabilities to lead meaningful lives. And Mike Marge was credited at that time for saying people with disabilities are at risk for a variety of health issues that public health isn't addressing but are preventable. And there's lots we can do. And the council said, okay, we will fund that. And I will say, there's a lot in that story that we can unpack, but the thing I really want to center is that until the medical experts who had innovated folic acid and had been looking at spina bifida for a long time shifted power, there wasn't that conversation about what was really needed, and a recognition that there needed to be this interdependence with the community as represented in the council, the National Council on Disabilities. I just wanted to bring that story forward and just say there's a lot to unpack there. One, right, that we can fix disability. That's a myth. Disability is a natural part of the human experience. That disability is equivalent with poor health. That there are things we can address and things we can address as a medical field, and we're going to focus on the things we can instead of the things that matter to the disability community. There's a lot there, and lots of people have written about this, but it is, and I am trying to do this every day, right? Understand my own ableism and how that affects the opportunities that I have to include the disability community in advancing health equity. But I think we all need to do more to be looking at how we perpetuate ableism and all the aspects of ableism and how they play out in the lack of opportunity that the disability community the lack of opportunity that the disability community has experienced in terms of research for health. I also just want to bring forward that there's very low expectations for people with disability to participate in anything. Whether it's school, whether it's a work outing, they won't want to go. We don't need to choose an accessible restaurant. And similarly, in research, right? When we think about the pillars of wellness, one is altruism. So the opportunities that the research community provides for people to give back by participating in research, if they say, oh, people with disabilities cannot participate, they maybe won't want to participate, they can't do these activities, therefore we won't include them. All those are part of those very low expectations, and in the end limit opportunities for people to be well through an altruistic act. And just want to be thinking with you about that too, like how this project is really trying to change that, and obviously needs to do more, but there's an agenda and there's opportunities to be working on that.
So that's a really good response. Thank you very much for that. Mark or Anthony, did you wanted to weigh in on this one? And we're going to run short of time really quickly, but this is like the foundation of why this program is important, but why, with or without the All of Us program, we need to have disability and health researchers that are researcher advocates from my perspective. But Mark, I know you know some of the history and the focus on the rehabilitation side of things. Is there something you wanted to add to Meg's response?
Yeah, thanks, Charles and Meg. This is Mark. I just wanted to call out something that Meg said and really highlight it, and that is the concept of ableism, and the way that underlies a lot of decisions that are made in research about who gets included and who's not. And this audience probably is familiar with the term of ableism, but understanding it as a way of thinking or assuming that able-bodiedness is the norm, and designing for some kind of normative experience that isn't really true, not designing for the broad diversity of human experience in their bodies and minds. And so I think we have to really name it, that ableism is a form of discrimination, and therefore it is something that we need to actively push against. And so when we think about that, I think it's also important to name that most ableism is not explicit. It's not people thinking, oh, I just don't want people with disabilities around. It's really implicit. It's something that that is not observable. I mean, we're not thinking about it at the level of our conscious mind. It's unconscious, and we make decisions without even thinking about the effect of those decisions. So I think I just wanted to call that out, Meg, because I think what you were saying really ties into this, and being able to name it and say, these are ableist practices, they discriminate against people with disabilities, they're results of implicit biases, and then to say, I need to think about my implicit biases. I need to sort of interrogate my own ableism for researchers, because I don't think, that hasn't been a conversation for researchers in general.
Correct. And in fact, a lot of times if you had a disability coming up in the years past, you couldn't admit that you had a disability, or you would be kind of the token person with a disability in an academic department. The phrase, privilege, humility came to my mind as you were speaking, Mark. Anthony, did you have something you wanted to add as well?
I do, because this is Anthony, by the way. This really gets at something I've always struggled with. As I mentioned before, I am a person with cerebral palsy. And so a lot of the times, and I know others have disclosed whether they do or do not have a disability. And this is something I always think about. What Meg said about shifting power is something that as a younger person, like I never understood that growing up. Like I grew up in Massachusetts. My family sort of let me do everything. I never experienced some of what folks are talking about personally. And I think it's a really important thing to have folks with that outward perspective, because sometimes I forget, right, that there are these issues because I can't always see the forest for the trees, for a colloquialism, right? So I think it's really important to have people, and I tell this to folks that ask me about it all the time, if I'm getting these things or having things in research or life happen to me, it is important to have allies that aren't as tired as me sometimes in dealing with it personally. So I think hearing you both say what you've just said about sort of the calling it for what it is, right, reminds me that as a foot in both camps kind of person, right, it's a great reminder for me that sort of this is where the work is and where it's going.
That's great. This is Charles. It reminds me that the program, the All of Us program, is really focusing on health equity, but there's so much work to be done to get to that place for all of the groups that it's really targeting, and then taking that to other federal agencies and the work that they do, these kinds of perspectives. So I'm going to follow up with you, Meg, and I'm going to try and get a little more concrete. So what could NIH do? What could other federal agencies supporting research do better to include people with disabilities in health research?
Thanks, Charles. I do want to recognize the leadership that NIH has created, organized around this question. And there are some important reports and an important designation of people with disabilities as a health disparities population that NIH just made. Obviously, it was a multi-pronged advocacy approach, and but I think that I'll pull that report in and suggest that people see some of the recommendations. 9, 10 recommendations that NIH can do, starting with, updating the NIH mission statement. I mean, when we look at Healthy People 2030 as disability and health researchers, and we see reduced disability, that's hard. It's hard to go from there. It's hard to keep reading, right? And it does take a lot of application of different frameworks to say, okay, I can kind of understand where they're coming from, and maybe we can partner on this, right? But at the end of the day, we do need to have clarity in our how we frame our problems that we're all going to agree to work on. And if we mean functional limitation, then let's say that. If we mean increasing opportunities for participation, let's say that. If we mean decreasing pain, let's say that. But at the end of the day, just really trying to be thinking with some of the work of the National Council on Disability and their framework for reducing health disparities. Some of the work of people who have participated in those leadership opportunities that NIH has created to say, how do we do better? But across the board, just looking at the organization and looking at ourselves and how we can be centering the most marginalized within the disability community. I think we have had some opportunities to be working on disability and health issues within the research agenda, but we need to do more to center the lived experience of people who are members of other underrepresented groups, multiply marginalized groups. People who are Black, Native American, Pacific Islanders, Asian, people in rural areas, people are LGBTQ, and really bring those forward into the opportunities that we have, and using our intersectional approach. All of that is really important, and I just want to give space to people to be contributing to the chat as well, and also to my co-panelists on this, because there's a lot that can be done, a lot that's been written about. I will say how important to me it is for NIH to be as a rural community with, fewer healthcare resources, more community opportunities, how important it is for NIH to be coordinating with the investments of other agencies, because it is a multi-pronged approach for advancing health and participation, meaningful lives with people with disabilities. It is working with NIH opportunities to be advancing health and medical practices, but those need to be in coordination with investments in increasing employment opportunities, improving the accessibility and universal design in our communities, increasing access to education and equity in our education advocacy resources from a very early age forward. And I just really want to be centering, the promise of community-based participatory research and participatory action research, to be working both at the research level, working on maybe a specific agenda with a group that may be experiencing a certain health issue, to be working with the community and how we can be creating both person level as well as community level supports for long life, healthy life, meaningful life. So I think we have a lot to do there to, when I started, I had to write, all about community-based participatory action research and participatory action research. We have a long way to go to adopt that and do it in a way that's acceptable to the disability community. And I'll really, just kind of pause there.
Thank you. This is Charles. I think it's a great transition point. A quick comment. Sometimes we say NIH, we say all of us research program. There's significant deficiencies from my own perspective in the greater NIH in a lot of areas. So I can imagine that there's kind of a general disability community member out there listening to this discussion, and it seems like there's a bunch of researchers here criticizing the program. What we're really addressing is the broader disability and health research and this unique opportunity to influence the All of Us research program and use it as the basis for a model for other NIH and other federal agencies doing disability and health research. In fact, you, Dr. Harniss, have some experience working with large NIH measurement development project where you helped researchers think about this concept of, well, how do you create accessible measures if you're going to be doing research? Can you talk a little bit about the technical aspect of involving people with disabilities in health research?
Sure, yeah. And of course, full disclosure, Charles and I talked about this in advance, and I said it'd be really great if I could have a PowerPoint. So I am the only one who has a PowerPoint, but I will go ahead and share some slides because I think it will help in this conversation about really how we can think about accessible research design and ensuring that people with disabilities can be included. We talked about ableism a little bit earlier, and obviously ableism affects people in a lot of different ways. People with disabilities have less college degree completion, their access to healthcare can be reduced. We know, for example, that women with disabilities receive fewer mammograms, people who use wheelchairs are less likely to be weighed, etc. There are challenges in effective communication. Transportation is a major barrier for people both in employment and in access to health. And people with disabilities are employed at significantly lower rates. And this is all connected to ableism and bias. And today, I just want to talk a little bit about how it also affects inclusion in research activities that may be very relevant to people with disabilities and where the findings may really benefit from them, So exclusion from research may happen for a couple reasons. It may happen because researchers just don't plan for inclusion, and therefore the research environments, the measures, the procedures are not accessible. But it also happens intentionally when researchers explicitly exclude people who they feel may be, quote, difficult to include. So for example, people with speech disabilities or intellectual disabilities, or people that may just take more resources to include appropriately. So moving towards inclusive research really requires a lot of change on the part of researchers. And some of that change is concrete, like changes to recruitment strategies. And some of it really requires changes to values and the ways of thinking about disability within the research community. But when inclusion is considered an important part of the work by researchers, it really requires them to develop an understanding about what it means to work toward accessibility in all research settings. And there are lots of definitions of accessibility, but I like the one, this one that's used by a number of organizations. Accessibility is giving equitable access to everyone along the continuum of human ability and experience. And it encompasses broader meanings of compliance, but it also refers to how organizations make space for the characteristics that each person brings. So in the next few slides, I'm going to give you a couple examples of accessibility challenges in research. And Charles mentioned that I've done some work in measurement, so I'm going to start with a measurement example. I know this isn't a pretty slide, but I'm not a great artist, but it's meant to help show how measurement systems can be developed in ways that are inaccessible to people with disabilities. And so this slide shows some key steps in the process of instrument development, as well as in the interpretation process. So if you think about it, let's say we have a big research study, we have a measurement expert, they want to measure something, let's say it's a cognitive task, they're going to use a computer to gather that information. They develop that task. Let's see if I can make this work. They then work to implement it into a system of some kind. In this example, they're using a computer, but they get those abstract measures and ideas and they make them real and administratable. And then participants have to get some information, some test stimuli from the computer. So there's a presentation format on a computer that's, in this case, visual or auditory. Those individuals then have to process the information and then they input their response. And in this case, this is done by activating a mouse or a keyboard. And then finally, the expert gets what they assume is a valid or interpretable score. And so when we think about bringing disability into the mix, we realize there are a couple of spaces where this may break down. First of all, if information is presented in a presentation mode that's not accessible, then the individual can't access that information. And this can be in a sense of like literally not being able to access the information because they cannot see it or hear it. But it also can mean more subtle things like they can see it, but not well, and it affects their performance. And so these are ways that can cause challenges in the response from the individual. But let's see, let me get but the other challenge can be in the way in which, let's see, I think I just lost my track. Hold on. I have too many little animations going on. What I was going to say though is it can also affect the interpretation of the results on the side of the researcher. So it can actually affect the quality of the science, and that can be problematic as well. So the way that it's received, information is received, their opportunity to give information back, if somebody doesn't use a keyboard or a mouse, and then the information as it's interpreted by the researcher can be incorrect. And so here's an example of an actual measure that's part of the NIH toolbox. It's a measure called picture vocabulary. It measures receptive vocabulary. And so in this assessment, the respondent is presented with an audio recording of a word and 4 photographic images on the computer screen, and they're asked to select the picture that most closely matches the meaning of the word. For example, in this case, the word is banana. So you would select that lower right-hand box. And you can see along the right-hand side that there are lots of task demands here. There's an auditory demand. You have to be able to hear the words. There's a visual demand. You have to be able to see to identify those photographs. There's a cognitive demand, which is actually the thing that's being measured. And that's what the information somebody's interested in. But there's also a motor or physical demand where somebody has to be able to move a mouse to select and choose. And so you can see that if somebody is unable to hear, their performance on this measure might be quite poor, but it's not because they don't have good picture vocabulary. And so there are ways in which research and research measures are designed in inaccessible ways that makes them invalid for people with disabilities. And we're going to talk a little bit about what happens, but I see Anthony's hand up, so I want to stop for a second. Anthony, can't hear.
Yeah, hello, can you hear me?
There you go.
Oh, as it happens, every call I have double mute and don't realize it. Sorry about that. This is Anthony. I just wanted to add that what Mark is saying is something that I, over the course of time in my professional career in digital accessibility and gaining those skills, this is something I think about a lot, right? And it's more qualitative than quantitative for me because I also come from the lived experience of having to deal with certain physical issues in my own life, right? So what we're really talking about here is the human element and meeting people where they are, right? Even though I am an individual who uses a manual wheelchair, I only know my own experience. And so my mantra has always been, and Charles knows this and others that I've worked with before, being in compliance with the rules or the laws is not always necessarily going to get you the results because it's not as usable as it could be. And that gets way down to the individual level. And I think that is something that when we talk about research and having access to research is something that isn't intentionally forgotten, but is really hard to do because so many people have so many different needs. And I think what Mark is getting at is sort of that aspect of things. So I wanted to add that before we moved on.
Yeah, thank you, Anthony. Oh, sorry.
Hello, Mark. This is Jacob. I think since we're kind of at a natural lull, there's a question in the chat, and also I want to bring that up. This question is for any of the panelists from Morgan Davis. Do you all do a lot of qualitative research about intersectionality in addition to numerical? Additionally, there was a comment just thanking you, Mark, that what you're describing happens to a lot of people in the hard of hearing and deaf community frequently. So I just want to, shout out the comment, point out the question.
Great, thank you. I'll just quickly say I think it's really important to have both qualitative and quantitative research in this area, and a lot of the really rich work is happening in qualitative spaces. Megan, Anthony, I don't know if you have thoughts there or.
I mean, this is Anthony. I am not a researcher by training. All of my evidence is anecdotal and qualitative from my own life, right? So, I can do research, I have, but, not in the professional setting. But I think it, like Mark is saying, that's a very important piece, right? The numbers don't always match up with what's happening. You need that qualitative piece, and you need somebody who knows how to do that effectively in order to get the results you're trying to get, if that makes sense.
Yeah, this is Meg. I think that's a very important story. Stories are so important right now. When we talk about evidence, levels of evidence, we need to be recognizing that, again, there are still barriers to people contributing to the evidence. And so having stories, creating opportunities to bring forward qualitative data that may, change the track we're on. I'm thinking about a study I was involved in as a graduate student. I'm just helping as a research assistant at the time on a longitudinal study that was looking at early development with deaf and hard of hearing infants of hearing parents. And it was being conducted at Gallaudet. And I imagine that there were stories that came forward that was not enough data, and that, you know, deaf children of deaf parents were graduating on par with their peers on math and on English, and that there's something to be looking at in terms of what deaf parents were providing to their deaf kids. And, you know, that was pretty radical at the time, but it added a whole arm to that research, and really showed how important having access to a full language model during those sensitive phases for cognitive and socio-emotional growth is really key, right? So yes, you know, that's years ago, but I think those lessons are still needed, and we need to be informed by the qualitative research. I'll also bring forward, you know, the concerns method report Steve Fawcett has really put forward as a way to center the lived experiences, the community members in building a research agenda. And that is, you know, the challenges are, right, when you do this kind of work, it's not necessarily the 1 year or 2 year or 3 year or even the 5-year project that is for which funding is available. It's a long-term commitment to really starting with the stories and level setting the expertise between researchers and community members, so that together you can be working on an agenda and making change.
This is Charles. I'd like to make a little bit of a shift now. Mark has presented this kind of description of the researchers and how you can be thinking about these sorts of things. Earlier, Anthony was talking about, well, what has his experience been like in health research settings, or specifically to the All of Us research program. I will say, in relation to the qualitative research question that came up, the lives of people with disabilities are so complex that a simple number is never going to be able to tell the story of what our lives are like and how health can be advanced. But let's hear from Anthony. Anthony, technology. I know you're a tech guy. I know you're accessible tech
I try to
guy.
be.
You do. And technology is great until it isn't. So tell me a little bit about when you have medical researchers or healthcare professionals using their tools of the trade. What is it like for you then as a participant in a research study, as somebody with a disability?
It is really wild for you to ask me this question now in this stage of my life, because, you know, I've always had cerebral palsy, right? So that has always been a part of my whole being, right? But I got real familiar with this kind of issue, not necessarily related to the All of Us program, although my interaction with the program has been through the surveys. I actually joined during COVID, so there wasn't a lot of the in-person work being done at that time. But after I joined, I personally got really sick, and we didn't know what it was, but everybody assumed it was long COVID. And ultimately, it turned out to be that I had Hodgkin's lymphoma. And there were points during that process of figuring out what was going on with me that I had to go in for different scans, different PET scans, x-rays, all that sort of thing. And the place where I went to get a scan for my chest to see whether it was pneumonia or something, only had a standing, and this was a screening place. They were designed to do x-rays. They only had a standing one. And the technicians were very nervous about me standing to do this x-ray and did not believe me that I could do it, and almost did not do the scan after waiting for an hour and a half, right? Which did not happen. I will say my wife was there. We had a whole thing about this, but that is one example of if I never got that scan or we didn't rule things out just because I used a wheelchair and people were nervous about not following certain rules or procedures, that is a way in which, even though it's not all about the numbers, those numbers are important sometimes. And I think, especially as we talk about research like this, if we don't have the methods, it wasn't that people were trying to be, bad towards me, right? But I did not leave that place without getting that particular scan, given that I knew something was wrong and at that point did not know what it was. So, I mean, I will say, just for everyone's edification, I did go through chemo and everything is fine now. But, getting to that process can be a sticky situation for people like me or others that have different disabilities than me, that need to be weighed, that need, when they ask me my opinion of whether or not I should be weighed today at a chemo appointment, I should not have the option to say, no, you need that data. I need to know where we are. And these places and the way we collect that data should be ready for us, because that is the purpose of collecting it.
So this is Charles. This is a follow-up question for you, Anthony. You have volunteered that you're a participant in the All of Us research program. Were you able to provide a height and weight measurements when you enrolled in the program?
No, not at the time, right?
Yeah.
And because of everything I just described, I did not obviously follow up at, when you opened up for in-person. I could probably do it now. I could probably provide it through the app, and maybe I did, but I never got an official weight, right? I know my height, it hasn't changed. So I probably have given the program that, but my weight has definitely changed. So I should get a real reading on that.
Yeah. Yeah. Are there, Mark, this is Charles again. Are there simple approaches to this fundamental issue of height and weight that disability-focused researchers have tackled? I mean, you were displaying some pretty kind of high-tech limitations and needs. What about on the more fundamental side of height and weight?
Yeah, I mean, there's a relatively simple way to get weight for somebody who's in a chair, and that's to have a scale where they can drive their chair onto it. Yeah. Height can be a little tricky because you need to think about how you're going to measure that height in somebody who uses a chair, or someone who might have contractures. There's just some things to think through, but these are not particularly difficult things to think through. There are things that do require advanced planning. There are things that require you to think about them before that person in a chair shows up in your research study. There are things that require you to recognize that there will be people in wheelchairs in broader samples, that there will be people with all kinds of disabilities within your sample. And it's about, it's about trying to in advance, and Anthony started to talk about this, and I think Meg has as well, but there is sort of accommodations and compliance and what we can do to ensure that somebody can do something. But there's another way of thinking more about universal design, collective access, really more broadly, trying to be prepared for the diversity of bodies and minds that are going to be part of our research studies.
Did I see your hand up, Meg? It seemed to come up briefly and then come down.
I did. I just want to draw attention to Dr. Rader's comment. We need more leadership, right, across all federal agencies on the standards for accessible diagnostic equipment. If we are procuring equipment, again, we have to have the expectation that somebody in a wheelchair is going to show up. And we have to buy the equipment as if they're going to show up. If our expectations are low and we're like, oh, well, again, going to the implicit bias, right, that Mark brings forward, you know, and our confirmation bias, right, and how we fulfill all of that. If we don't have an accessible wheelchair scale, then our expectation is, right, that they're not going to show up. And so this is one of the strategies that the National Council on Disabilities has in their framework for reducing health disparities, is to really, you know, hold people to account when they're using public dollars to create infrastructure, to engage all members of the community in the opportunity to contribute to research, that they need to buy the equipment as if it needs to be accessible.
Mhm. This is Charles, and an audience member has pointed out that she's gone more than once to a veterinary office in order to be able to access a scale as a chair user. That I think speaks for itself. I also saw your hand up, Anthony, as well.
Yeah, I was just going to reiterate, I think something that everybody's touched on and said, though, is that whether or not the rules state that these things are violations, right? If there should be things, that doesn't help in the moment, right? And I think that's what everybody is getting at here about leadership and improving things from the beginning. Because while I know what the law says, we're still talking about the human element and the education of that. You know, many times in my life now, you know, people assume that the ADA exists, so, you know, there should be somebody to take care of these issues for you. And that's not necessarily, I've been in the space long enough and been in life long enough to know that that doesn't help me when I'm experiencing a situation, right? And yelling at the people at the office, or, you know, even advocating and not being rude about it, is not going to change that situation in that moment. And I think that's the more important thing we should be focused on collectively, right? It's like, yes, rules exist, so these things don't happen, but they still do. And why is that? And how are we going to get there?
Mm-hmm. Thank you so much for that, Anthony. It's a really nice segue to kind of closing up this session, which I would be really pleased if it could last at least for another hour. This conversation has been so dynamic. The points I think are really germane. I will say this, you know, we point to the All of Us research program because we think we can have influence with it. We endorse the goals that they have around health equity and individualized health care. And so we encourage, you know, audience members to enroll into the program, learn about it, enroll into the program. And if you run into these kinds of accessibility issues, then you let us know, because I meant it when I said philosophically, it's the responsibility of this project to tactfully, consistently let the All of Us research program know when they're deficient. And that we hope then that that will influence the other institutes within NIH and other federal agencies. But this is such a rich opportunity for us, the members of the disability community. And I think for training a new group of disability and health researchers so that they know about the things that Mark was demonstrating a priori ahead of time you're thinking about this. Finally, I want to say, I want to thank so much Anthony and Mark and Meg for their participation in this. We do have an evaluation a survey that's there in the chat. Please fill it out. We'll be having 4 more of these with additional provocative topics, and that we hope you participate in those into the future. And then a really big shout out to the staff of the DSEP itself that worked so hard to make this webinar effective, including and when you start naming people, you lose if you forget someone. But I will give a shout out to Michelle Sales, who's been organizing so much of this, Jacob and Nuria for the assistance, and the rest of the team, because everybody has contributed to this event. So thank you again, all of you, so very much.
Thank you, Charles. It's been a pleasure.